Thank you. I'm here basically for two reasons. One of them is EIT Health, which we held some workshops, and you've heard about yesterday, and we had some workshops on Wednesday. And the other thing was meeting Jerry O'Dwyer in Stockholm a few months ago, and we were talking about the challenges that are facing hospital managers. And he opened this conference talking about that and talking about that the future is now. And having had a chance now to reflect over this few days, I see an interesting combination where we have industry, where we have researchers, and we have managers and practitioners. And we open our talks with a lot about the problems, and then we spend a lot of time talking about solutions. I think if we turn off this one. Can you hear me? Yes, good. So if we talk about solutions, but the thing about solutions, especially when we enter into complex environments and complex contexts, is that the solutions are never really as straightforward as we think they are in the beginning. And a lot of times we're missing out on two vital ingredients, the context and the process. And being in research, it's a wonderful place because there's two things that are very important in that. And to symbolize that, we give all of our newly PhD students after they've gotten registered two things. The first is a clicker, and that's because it's important to leave the safety of the podium and the walls of the research institution and actually work with the people that have the challenges and they're facing those challenges. So all of our research is driven and all the questions come from practitioners. The other thing is that we give all of our PhD students an article which talks about the importance of being stupid. And being stupid is basically knowing what we don't know, or being aware that we don't know something. And the way out of that stupidity is by asking questions. And I think that's a challenge that I would like to leave with you as you move forward, thinking about we have lots of solutions, we have lots of problems, but if those solutions are actually going to work, we have to realize that it's about finding responses and learning along the way. And that's basically what we do in our research group, that we work with practitioners, we use a number of different methods, we're looking at a number of different of the challenges and trends that are going through healthcare. And we do this both with practitioners and also doing it in education. And we try and combine these at the same time. So we send out our students to work with organizations around Europe mostly to address the challenges they're facing and try and crystallize theory that could help other organizations. I want to start with just two questions. And the first one is, how many here feel that you are better than average drivers? If you raise your hands. All right. Okay. This seems to be a very honest group. Yeah. How many of you are better than average when it comes to leading change? 1, 2. Wow. So this, I think, is a really good start. Because a lot of times when this is done, we find that about 96, or depending on where country you're in, a lot more than average find that they're better than average. If we come back to this, but just start with what change is. The essence of change is attention, right? And that tension is between what it is we want to achieve and where we are and what we're doing today. The question then, of course, is what are we doing today? And during my medical school experience, I found myself basically at every rotation sitting there listening to the staff and reflecting on myself that there's got to be a better way to do things. And I constantly and consistently hear this over and over again. There's a frustration and the feeling that something could be done differently. And this is shared by everyone. It's not just the staff in the hospitals. Politicians are, at least in Sweden, are very involved in this question as well. And then the question in this case here, can management be part of the prescription? And it can be, but not always in the way we think it should. Management tries a lot, and we import ideas all the time into healthcare. I don't know if people are familiar with Kieran Walsh's article, but what he did is he went through Medline and looked at a number of different quality improvement approaches and followed their up and down over the course of the years. And in this, he found a pattern of going up and falling down 3 to 5 years. So those of you working with technological diffusion of innovation, this is really good news, right? Because diffusion of innovation is around 3 to 5 years. But when it comes to getting a return on investment from introducing a management idea in the context of a hospital, Anthony Staines and colleagues found that it takes around 17 years, right? So we talk about waste in healthcare. We're talking about process waste. A lot of those working with lean want to get rid of this waste. But one of the sources, perhaps, of waste is not implementing these ideas and investing the time, which is 17 years, to really get a return on that investment. Because every time we switch, we end up wasting time, wasting resources. And this is why that question of what's average success, and I'm sure many of you have seen, Harvard usually sends out as part of their business press advertisements that 70% of change efforts fail, and therefore you should read their books. So being above average in change is quite impressive if that's something you're able to do. And that's the question, is there a better way to do this? Well, one of the challenges is that when we look at this diffusion of management ideas in healthcare, is that the differences between them are very, very small. And this is why Kieran Walsh dubbed it the pseudo-innovation. We fall for the packaging, for the wrapper and the ribbon, rather than the content inside. We also find that when we do apply things, and this is Julie Reed and company in London found that less than 20% of those people using PDSA wheels, the cycle, or the Deming cycle of improvement, use it as a cycle, that they do it once, right? So the fundamental principles of a lot of these management ideas aren't being applied. And then, of course, there are economic gains, and you know, you could end up in a conference talking about these things. So there are reasons for perpetuating a lot of this. And then the thing is that the recipients, I mean, most of you that are interested in finding solutions to the challenges you're facing, you want quick fixes. And that's not so strange when you consider all the pressure coming from many different directions, asking for, let's do something. So value-based healthcare, there was a session about value in healthcare, and it's been named in many other presentations. We were just thinking, well, at the start of value-based healthcare, which is a few years ago, what are the chances that value-based healthcare will go the way of a lot of these other management ideas? So we took an article written by Porter, which we designated as one of the start articles. Is called What is Value? And we looked at all those articles that had been published up to that point in time that cited that article. And then we went in and looked at what they were citing. What we found is that most of them cited the term value in the value definition. But the other areas weren't cited as much. The interesting thing is that that article isn't actually about value, it's more about how you measure outcomes. And then we used something called the Biggs Solo Taxonomy, and I'm not sure if anyone has come across this, but it's a way of measuring at the university level how well a student has understood a concept by analyzing what they've written about it. And there's 5 levels to that. The first one is 0, so that would be an empty circle. And then the top level, which is the ability to relate that concept to many other things and really understand how it can be adapted to a situation. And everything up to a half circle is basically what we call surface understanding. That you understand the concept, you're familiar with the name of it, but you aren't able to really explain what it's about. There's this term that was popular in the 60s called grokking, and grokking would be a full circle, but not really understanding something, then you get the surface level. And the danger with the surface level understanding is that we support the development of buzzwords, which is also known as bullshit bingo, if anyone has played that. If we look in depth at this understanding, we find that 0, so the red part of this pie diagram here is pre-structural learning, which basically means you don't get it at all, right? You have no understanding of what the concept is. So more than a quarter of the articles that were writing about value-based healthcare had no understanding of the concept. The other part that's a little scary with this is that the extended abstract, the really deep understanding, the one that allows us to apply and adapt and you could say improve the theories of value-based healthcare, no one was at that level. And this is perhaps something that will change over time as we work more with these concepts. The other thing, though, was that the higher the impact factor of the journal, the less the concepts were understood. So that says something about credibility in science. So if we take a step back, and there has been a number of people that have mentioned the triple aim and the quadruple aim in healthcare. So if we say that the triple aim is that there's three things all healthcare organizations strive for. It's to improve patient experience, it's to improve health outcomes, and to do all of this at a lower cost. The quadruple aim adds that you have to feel good doing it for the staff, and I actually see that more as a strategy and not an end in itself. But we said, how does this reflect in a healthcare organization? Because this sounds really good, but if you're working in the organization, what does this mean for you? So we went to a university hospital in Denmark, which had been just faced with a downsizing demand, and that was a result of these 16 super hospitals that they're creating there. This was an obstetrics and gynecology department, and we asked staff then, how do you view these? And the interesting thing then was that the physicians, they saw healthcare as about improving health outcomes, and they understood that cost was a part of this. The nurses and the midwives, they saw that it was about the patient experience, and they understood this thing about cost. So already there we see a difference in the staff of a hospital department about how they view the triple aim. The managers in Denmark are all clinically trained, and there were three of them. And one was a nurse, one was a midwife, and one was a doctor. And they actually understood everything, which I think is quite unique. We have not asked patients, but of the patients we've talked to, our guess is that they will end up somewhere where the focus on the patient experience and the outcomes. We have talked to a lot of politicians, not in this study, but we placed them here that there's a focus on reduction of costs. And every politician we've talked to is that seems okay, except we should actually be outside of the triangle, further to the right, really focusing on costs. But then we did something different, because this is one way of just saying that there are differences in how we view healthcare. But we tried to explain what are the mental models behind this. And the reason for this is IHI, which originated this idea of the triple aim with Berwick, claimed that to be able to achieve the triple aim, to pursue it successfully, you need to change your mental models, the assumptions we're making about how healthcare is run and should be run. So we tried to find mental models that would explain these discrepancies. And what we found was two concepts that were very clear and very important. One having to do with what drives change in healthcare, and the other one, what are the economics of healthcare. And we found a dominant trend among the staff and a dominant trend among the managers. And for the staff, the question of what drives change in healthcare, that was research, it was evidence-based medicine, and it was technology. And that's actually a lot of what we've been talking about these last few days. Managers, for them, it was a socio-political discussion and discourse. It was what the politicians were talking about on TV. And one of them said to their staff, just look on TV and you'll know what we'll have to do in 2 weeks. When it came to the economics of healthcare, the staff had what we called a grocery store model of economics. Is that if you have a lot of money, you buy a nice juicy steak. If you have very little money, you buy a sausage, a hot dog, right? And for them, less money meant lower quality. Managers saw instead less money as a reason for driving quality improvement. And quality improvement has basically been in healthcare since the late 80s. And one of the sort of tenets of quality improvement is that by improving quality, you get reduced costs. So you could say that despite quality improvement being in our context for so long, none of the people we talked to had a model of improving quality to drive costs down. Instead, it was the other way around. So reflecting on this, we had a lot of people writing about this, and in the Swedish medical newspaper has described this as the most important part of this is that there's a leadership crisis. And as I say, that the medical profession has spent too long looking at the biology of care, but not at the processes of what's actually going on. And the solution then, of course, is that we need to improve management. So it's not about the lack of resources, but it's about bad management. This, of course, creates a lot of stress, and this is something that one feels as a manager in healthcare, but there is, of course, evidence-based hope for that, and that's mindfulness, compassion, having hope, or, which I really liked, Argentinian tango. But part of this problem, and this is the part that we need to stop doing, is how we view the role of leaders and managers in healthcare. And there's a lot of us that still go around with the idea that it's the great man, and we mean man, who solves the problems, right? And moves things forward. And this is an idea that we still see rampant through politics today. But you know, in Sweden, we have our own version of this, and it's actually much more along the British ideal, which is the big hero is the dead hero. And we're still thinking about Karl XII and how he could have changed things dramatically and gloriously in Sweden. But death is an important part of being a leader. And we have, of course, this version where it's not so much a great man, but it's an ordinary man who finds himself in great circumstances. And this is where we get this idea that every man dies, but not every man really lives. And this is what we call contingency theory. We've somewhat moved on, although we see a lot of this still. And I just want to share some thoughts on one of the theories that's become very popular in healthcare called transformational leadership, which consists of 4 different aspects. And I've gone to a lot of conferences now where this is lifted up, and there's a lot of surveys about measuring this. The interesting thing is that the first 2 of these are what contribute to charisma. And you can, actually, if you go to TED Talk, you can see a great talk about how the importance of charisma. And these are all aspects that do work, right? Just like the great man, there are all aspects that through history we can find evidence and support for these things. But in the context of healthcare, I think this is somewhat troublesome, and for 2 sort of aspects. In terms of effectiveness, it's something that we talk about, it's something we dream about, being inspirational, right? And it's a trait or attribute that's most frequently demonstrated by physicians who are involved in leadership. It's also the one of the most valued by physicians. However, it has the least impact of all of them on staff satisfaction. And if you start digging through the material and the evidence that's coming forward, we find that this type of leadership is almost like a lot of the other management ideas, more of a trend rather than having substance in what we do. And there's been a few places around Europe that have had to wrestle with something that we've had at Karolinska, which is the ultimate result of charisma, which is getting people to do things they didn't think were possible, right? And in the case of Karolinska, that has been the ability to get people to basically operate in a garden hose as a trachea. And I think that's something that should give us some pause when we talk about transforming organization, getting buy-in, convincing people to go against the medical conservatism. That actually is one of the most important attributes of a healthcare organization, because it helps keep healthcare safe. So if you go into sort of management and what's happened in the discourse there around leadership, Jim Collins came out with a book in 2001 called Good to Great, and there he talks about something called level 5 leadership. And the difference there is that it's about leadership that's not good for being an author of books on leadership. It's the kind of leadership that's good for the organization. And what makes these leaders stand out are that they have a personal humility and a professional will. And therefore, they aren't noticed the same way we notice great male leaders, right? And the analogy he uses is to think of this as a window and a mirror. The difference between level 4 and level 5 is that when you look out the window, you see the team that makes all this wonderful things happening, this transformation possible. And you look in the mirror and you find the challenges and the problems. Whereas if you're a level 4 leader, a great man ideal, you look in the mirror and you see Rambo, the kind of person that's going to solve all the problems despite, when you look out the window, all the people that stand in the way. If we see this then in the context of healthcare, a lot of the ways we view change are tied to views of the change processes that require convincing others, to get buy-in, to make them do things they hadn't thought possible, to motivate them extrinsically. So what we did then is to try and look at what are the things that actually seem to be connected. So we found a study by Sarto and Veronesi, which found that there was a connection between physicians being managers and being in the boards of hospitals, and a number of aspects tied to the quality of care and hospital performance. In their analysis of this, they come up with a lot of suggestions, but their suggestions are taken from the discussion part of articles, which is basically the speculation area we have in research. So we decided to look at this more in depth and to explore, are there actual things that could explain when things go well or poorly? Because having a physician in your leadership isn't necessarily, it affects these things, but they can go bad as well. And the difference, and you're not going to be able to read this, which is good, a little bit you can read, unfortunately, because we haven't published this yet. But basically, we have a red circle, which is this vicious cycle, which is based on the idea that we try and convince people to become leaders. This is what we call the incidental leader. And we see this also in healthcare, where around 62% of managers are recruited from outside the organization, which suggests that we don't have a way of developing leadership within the organization to achieve, and we don't see it as part of our organizational strategy to achieve high performance. Those places that do find a positive relationship, they invest in their leadership by working what we've dubbed management through medicine. So, and to get more at that concept, we were inspired by the writings of Boyatzis at Case Western Reserve, who has developed an understanding that there are threshold competencies to be a leader, things that everyone should do, but then there are a few distinguishing competencies that lift that to a higher level, and these are the highly effective leaders. So we decided to switch the traditional view of research, which is look for barriers and to change, and we instead decided to do a root cause analysis of success. So we identified we tried the group that's at 30%, and we found 10 managers in Sweden that were senior managers and 10 that were emerging. And we then interviewed them and asked them to describe situations where they were successful, and we were aware that they had also been unsuccessful in other aspects. And what we found was that when it came to their characteristics, there were 4 things that stood out: a clarity of purpose, a positive outlook, endurance, and authenticity. And in that authenticity was also a deep humility. And this was actually something that you could relate to this idea of a growth mindset, that we are aware of what we don't know, that we are willing to feel stupid in the service of advancing our own understanding. When so much of healthcare, especially for doctors, is about showing your infallibility, that you are right. And that's why there's a dominance of a fixed mindset among physicians. The other things when it comes to what they actually did, and these were their capabilities, is that they grounded their management in medicine. And this was something that we hadn't seen before, but they would take the management decisions and they would constantly talk about the medical consequences of those decisions. And this was a way to integrate these 2 domains, which in general are incredibly hard to do that. So this wasn't the same thing as being a hybrid manager or combining things. It was to really look at what are the consequences if we do this for our patients. The other thing they did was they worked by working with others in something that's called teaming, where you team on the fly. And they were mostly doing this based on what they didn't know. So they would work with people who would complement their competencies, which required a high degree of self-awareness. They also worked very hard on catalyzing systems. So they had we were discussing yesterday about the butterflies and the tornadoes. But basically, to see the interrelatedness, the interdependencies within the hospital organization they were working with, or within the organization they were working with, And then they would catalyze it. They would get people to connect without them having to be involved. And a common way of describing this would be that they would go out and say, oh, you guys, you should talk with each other. I'll set it up and go and meet. But it wasn't go and meet with me in my office and talk. They were letting that go and letting go of that responsibility, but working to connect people. They also used a scientific approach to identifying and analyzing problems and then following them up. And a lot of organizations and consultancies especially use data, and we've heard a lot of talk about big data and data analysis. What they were doing is that they were using the data themselves. They were doing the analysis themselves with their team, with their people that they were working with. They weren't outsourcing that. And that made the need to change much more evident for them. And then they would follow this up. And we speculate that this had partly to do with the fact that so many of these people had PhDs. So they were learning that. Whereas in those who were trained as MBAs, they didn't have this humility in the same sense and weren't following this approach as much. So to get back to then the essence of change, the suggestion here is to think about why we are here, what we want to achieve, and then also then what is it that we needed to do today to get there. And getting back to the opening of this conference, if the future starts now, what do we need to ask to move us forward? And then the process to do that, and this is, I think, the most important of everything, is that if you leave from here, think that the way in which you apply these ideas and test these solutions that you've heard is really to live it as a leadership lab, to involve leadership and leadership strategies in your organization to achieve your goals, but constantly review and learn as you go, with us or without researchers in the process. But learning is the key. Thank you.